All right, let me introduce our instructors for today. First, we have Tony Moreno. He is our clinical applications trainer here at NovaRad. Tony has been with NovaRad for 17 years. Previously, he has worked on the floor as an X-ray tech for 12 years and trained as a radiology specialist in the U.S. Army. Next, we have Rhonda Hodge. For over 27 years, Rhonda Hodge provided compassionate, expert care within the hospital environment as a cardiac sonographer. Prior to joining Flexible Informatics, she managed a busy, non-invasive cardiology department and was an assigned leader in integrating a cardiology reporting system for a multiple hospital organization. She now brings the same level of expertise and passion for patient care to her work as a trainer, demonstrator, and application specialist of Encapture MD. Next, we have Craig Scott, MD, an engineer turned physician. Craig Scott decided to specialize in cardiology the day he realized that the heart is just a mechanical pump governed by an electrical control system. He later founded Flexible Informatics and developed Encapture MD based on his vision of a better way forward for healthcare at the intersection of medicine and technology. So at this time, we are so glad everybody's here, and I will turn the time over to our instructors.
Hey, good afternoon, everybody. This is Tony. I'm the applications team lead here. And today, let me share my screen. We'll be covering the NovaCardio. I'll just be covering the parts that you see in NovaPax, and then at some point I'll hand it off to the Encapture MD team, because theirs is the one that's actually creating the reports off. It's probably the part that you really want to see. So in NovaCardio, this is just an overview. It's a fully integrated cardiology solution. NovaCardio is a robust, full-featured CVIS and CPACs that can be used standalone or as an additional module in the NovaRad framework. Cardiologist design, web-based and scalable, NovaCardio can be accessed by your team from any computer within the facility or remotely. Easily add cardiology to your NovaRad system. NovaCardio will work seamlessly with your EMR and PACS. NovaCardio enables facilities to view and review both radiology and cardiology images in a single solution, allows your doctors to work from anywhere, on-site or remote, customize workflows, prioritize studies to meet SLAs for contracted readings. Features are single station to provide work lists with viewers for all cardiovascular subspecialties and non-cardiovascular imaging, reduce maintenance and and costs with a single solution built and supported by NovaRad. That's training costs, by the way, I missed an A. Automated modality measurement tools, web-based patient-centric universal viewer, and NovaCardio enables advanced structured reporting. Modality measurements are auto-populated, stay compliant with standard organizations like IAC, modality-specific rules-based error checking and billing compliance, reports, features, drawings, and automatically generated graphics. So that's drawings, my G is missing. Dashboards and reports include lab and staff activity, information, and turnaround time. And that's the end of the intro. And so I'm going to switch over to actually the PACS piece of how you can view these studies here. So I've launched into NovaRad already, and we identified some studies that we would like to, that are relevant to the Encapture MD and the NovaCardio piece. And they're big studies. I've retrieved them earlier. And then I even did one more step of prepping for this, as I've already opened them. So with that in mind, let's go ahead and take a look at some of the studies. So right now, this is one of the echoes, and you see it's on a 2x3 matrix, and I have it configured that if I roll the mouse wheel, it moves all 6 at a time. And you see that it's just CNAing them as they come across. So you can navigate through this whole study just by rolling the mouse wheel. I have a button here for launch cardio reporting. Once they are done with this study, this is what would launch the Encapture MD. And what would happen is the measurements from this study would be sent over there, and that's where that reporting piece would be. But that piece is going to be covered by Dr. Scott. From here, though, we can do other measurements. So if I right mouse click, I get this menu. And right now, I'm just going to type in the word echo. And I can just place those tools on the toolbar. So if I click it, these are the different measurements you can do again if you needed to. If you click on here, and I'm probably not measuring the right thing, you can see that it remeasures. And I did that twice, so that's why it looks like it's superimposed, because it is. If I can remove one. There we go, just down to one. So in the echoes, you can see that you're able to view them, and these are the order that they're captured. You can see that there are some static images, and they're the CNAs. They are big studies, so I do recommend that you retrieve them before you open them. So that's an echo, and that's probably the one piece that people always ask me about. So the next study I'm going to open is going to be a stress. So this is our new stress echo viewer. Previously, if you had been using us, you probably were using Showcase, but now it's built into NovaPax. And as you can see, there's tools up here. These are the different stages. So that's because it's on this first button for stage. You can choose how fast it's going through the images. The DICOM FPS would be whatever the modality, if we are able to do what the modality sent it to us. If you press view, it brings us a different view. So these are the different, this one's a peak here on the right, low dose here on the top right. It's the baseline on the left and the pre-peak on the bottom left. And then you can see I can press these buttons up here. There's also extra views if they exist. You can do more measurements here also. So this is the stress viewer that's now built into NovaPax. I do want to point out this is 8.9.3. On earlier versions, you wouldn't be able to see this. So the next study I'm going to look at is Rogers. No, maybe I have the wrong name. So it's a vascular. Give me a second. Let me go to my list. It's Rogers. So you see, this is just another study. And, the CNAs are here. And then you have the statics. And then so once again, I'm just rolling the mouse wheel to move between the images. The next study I'm going to show you is an ECG. So this is how an ECG looks in NovaPax if you send it. Not all machines can DICOM send. The doctor is able to sign the report here. I don't know if you see it. There's a sign and close over here. There's different tools here for this. There are different layouts. You can even measure here.
So Tony, just to add a little bit more color here. So there is a transformer box that can be added so that any machine, any ECG machine that can be placed on a network can go through the transformer box and be able to display ECGs within the system. So it does have more flexibility in that regard for older machines.
Oh, thank you, Dr. Scott. So after this, I want to show you the XA. So one of the tools we could use on this study is we do have the percent stenosis tool. I'll probably have to pretend if I don't see one.
And the other thing is that what I'm seeing is that it's not playing smoothly, and that's not to do with the viewer. It's the Teams is not able to keep up with the frame rate of the computer. You would expect to see these play smoothly as they go. There's no lesions here, Tony, so it's going to be kind of hard to do an analysis. But the point is that the analysis tool exists for those who want to use it.
Yeah, so one of the issues also with how fast this is playing is I'm doing this on a machine that wouldn't be a workstation that a cardiologist would use to read. This is a virtual machine, and I'm probably stressing it just by loading this many. And which actually reminds me, as far as tools that I wanted to show, is we do have the calcium scoring, which I went through with when one of the other clinical people at NovaRad, we went and we looked at this and we marked the tools here for the calcium scoring, which is this. So we went and we marked all of these. Basically, what we did is you would select a vessel and then you would draw around it and then it would capture here. And then I created a report off of it, which is what this is. So this is the calcium scoring report from the CT study.
And if you do the analysis on the CT scanner, instead of doing it here, which is fine, then we can import the values into the report in a very similar way.
Okay, hold on. Let me grab my machine again. Sorry, my main computer took over there. So these are the studies that we identified that I wanted to show you how we viewed them in NovaRad. And of course, this is just part of the piece of what we're talking about today. Dr. Scott, is there anything on these studies you wanted me to go over before I handed this to you?
I think there's a couple things to talk about in sort of big picture things. And one is that what I've heard feedback is that one of the really nice things about NovaRad and NovaCardio is that you don't need multiple systems to do this. In other words, right now you may have a separate echo system, a separate nuclear system, all these different separate siloed pieces of information with no great unification. And so the one thing that NovaCardio provides is a single system. And what I find really helpful is in my practice, I couldn't look at a echocardiogram on the same machine as a cardiac cath. I couldn't look at the patient's chest X-ray without, logging into another system or going to a different place. And so with NovaCardio, if I want to look at a cardiac study, that's great, but I still have the capacity to do I have the full packs. So if I want to look at the chest X-ray, I can look at the chest X-ray. I can look at the ECGs. It becomes a one-stop shop, which is really, it's a nice thing to have. And it really doesn't depend too much on the size of your facility. It's always that situation. So, and with respect to NovaRad, then you get all the benefits of NovaRad. You get, much better archiving, offsite backup, and definitely reliability, and a single vendor that you'd have to deal with in that scenario. So the NovaCardio supports all cardiology imaging types that we saw. We saw echo, vascular, with DICOM secondary capture. We can export nuclear cardiology studies, nuclear stress tests. It's compatible with all the different types of all of the studies. So for example, it's good with echo, stress echo, pediatric and fetal echo, transesophageal echo. It works for all of those, all the different vascular ultrasound modalities. And we even have radiology ultrasound modalities, OB and breast ultrasound as well. So it's a really complete package. And if you just do echo, that's great. It's modular in that way. Just do echo. If you have a full echo, nuclear, vascular, cath, even electrophysiology, we have modules for all of those things.
So Dr. Scott, do you want me to, if I click on this, so this is that button we were talking about earlier. This is what the structure report will send the measurements to Encapture MD by pressing this button, and it'll launch the reporting tool from there.
That's correct. And because we're two different people in two different places, we'll be kind of doing it in a different way. But when the user sits down, they click that tool, the report engine just pops up on the next screen. And because it has the full PACS capability, if you want you can do it on a single screen. You can do it on 2 screens, which is ideal. You can even do it on 3 with imaging on 2 of the screens and the report engine on the 3rd. It doesn't matter. However you want to organize it, that's fine. And so that button launches the reporting component and therefore transfers all the demographic information, all of the measurements that were performed on the report, and then allows for interaction. Tony showed a little bit about remeasurement. It's even possible to click on a measurement in a specific measurement in the report engine and cue NovaRad to redo that measurement on a specific frame. So highly linked together so that it will be a single workflow for all of the different participants. And the sonographer can review the images here. The attending can review the images here. If you have trainees, they can do it. And so it's quite a powerful tool, and it's flexible in the sense that there is a workstation component, and there's also a sort of a click once viewer that can be launched anywhere that it can see the as you all know. I mean, if you're all NovaRad users, a lot of these features should be apparent to you, but just keep in mind that they also apply very well to cardiology images as well.
So Dr. Scott, do you want me to log in here, or do you want to share from somewhere else?
Yeah, I'll just share from my screen, but the concept is the same. You click the launch reporting button, and then it would come to me.
Okay.
So that's what that button will do. So
okay. So
if I can take control.
Okay, do you want me to just give you control, or do you want me to stop sharing?
I don't know if you have to do both, but whatever. I want to be able to look at my computer next. So
Okay, so I'm gonna stop sharing then.
okay, I just asked to take control. I didn't get it. So let me ask again. Let's see.
Oh, I've already stopped sharing.
Okay. I think it's blocking on my side. One sec. I'm gonna turn on screen recording on my side to let Teams do its thing. All right, I have to, looks like I have to stop and restart the application, so I'm going to do that, and then I'm going to come right back. So, Rhonda, do you want to just spend a couple minutes talking about sort of general workflow in the various labs, how it works for the sonographer and the physician? I'll be right back.
Sure, that'd be great. Hi, everybody. I hope everybody can hear me. Yeah, Encapture can work with different workflows. We've had organizations that the sonographers do not create preliminary reporting. They do the echo, they send the echo over, and then the cardiologist would open the images, want to report, launch cardio reporting, and that would actually open the study in Encapture. So you only have one work list that you have to work from. As the images flow into Encapture MD, it will populate those fields, and then sentences start to develop, which you will see when Dr. Scott shows you that. Once that's done, the cardiologist can go in there. He's able to put in the abnormals, click all else normal, and pretty much the report is generated in a very short time frame. That also works the same way for the sonographer. If the sonographer were to be the one that is writing the preliminary report, the sonographer would do the same thing. So they would go in, they would launch cardio reporting, and then that's when they would check, like the measurements are all there. They would put in their abnormals, launch cardio reporting, and at that point, put it into preliminary. Putting it into that preliminary status at that point then can allow the cardiologist to see this in Encapture, and it's ready for them. And then when the cardiologist opens it up, seeing the images on one side and Encapture MD on the other, then the cardiologist, all he or she needs to do is basically read the report that's being generated and then click on those particular sentences if there's no agreement with the sonographer on a particular area and it wants to be changed. So we have different versions, and you will work with the teams to see and gather workflow. That's primarily what I do, to kind of see what's happening in the facility and how best to work with you and how best that Encapture could work with your particular flow. You ready, Dr. Scott? Are there any questions that anybody has? If you want to put it in the chat and I can answer them for you. I know there's tools within Encapture that we have developed to assist the team, such as we have gender-based measurements from ASE, and you can hover over a field and it will show you what those specific measurements are for a male and female. And then it will highlight if it's outside of that particular range. Dr. Scott will show you some of those. We have the diastology flow parameters in there. So you, instead of having it posted on the back of your desk or somewhere in your reading facility, you can just pull those up in Encapture MD. Okay, your question from is about the calcium score report. Okay, I think when Dr. Scott goes over that, he can definitely address that for you.
Okay, can you all hear me? And can you see my screen?
Yes.
At this point. All right, so I was going to start with an echocardiogram and just kind of go through this at a high level. I'm going to assume that the crowd is a mixture of administrator folks, and some clinical folks, just based on what we saw in the invites. But if I go too much one way or the other, in just somebody let me know in the comments. But starts out, there's a bunch of information that comes from the ultrasound machine. That would include information about the order for the study. That would have the patient's name, date of birth, medical record number, other identifying numbers. Also, the ultrasound machine is generating a lot of data, and that would be things that are entered, like the patient's height and weight, plus all the measurements that were performed on the study. So we can import all of those measurements, and then we start to classify those measurements, and those measurements actually begin to drive the creation of the report. I'm going to kind of show you that as I go. We can receive physicians who, if there's an ordering physician, we can track the staff who participated in the study. We can allow for various reasons the study is being performed, and we can have more than one. We can type a brief history. If you have speech to text on your computer, if you activate it, then you can utilize it. The patient is a 53-year-old woman with a history of coronary artery disease. And then I didn't trigger that right, but then it will flow directly in there. So you have speech to text that will work. The report keeps a chronicle. So every time somebody changes something, we'll record the kind of a snapshot of what that person did. And so if there's any questions later on about who did what, we can answer that. We have all sorts of patient information that we can import, including a list of all the doctors who have ever seen the patient, and this will accrue over time. We can handle billing. If it's handled already for you, you don't have to worry about it here. That's fine. But if it isn't, then we have the ability to know the CPT codes and the associated ICD codes. And so this list on the right is filtered based on the choice of the code, the CPT code. So it's really, and it generates both a professional and technical bill. Less important for echo, nuclear and vascular, is sometimes more important for cath and other more advanced techniques, but it exists for all of our applications. It's possible to take a screen capture. So if I'm linked to the viewer, I can send images, or I can just use there's a little camera icon that appears up here, and I can just click on that, grab a screenshot, and toss it right into the report. As I showed you previously for very short, there's a chamber and valve measurements. So these are all the valve measurements and chamber measurements that come from the ultrasound machine. There's a variation based on the person's size for what's considered normal. Gender also important to determine what's normal. If the system considers it outside of the normal range, it'll color code it as yellow. All of our range values are documented for where the range value came from, and they're all either from technical, clinical journals, or from national or international organizations, like in this example, the American Society of Echocardiography. So highly specific. And then there are also measurements that are calculated. And so if for whatever reason I want to remeasure something, I can just click here, swing back to the viewer, do my measurement, and the measurement pops back in here. And if I do that and it changes any value, and it's something that's calculated based on that value. So if I change this 5 to a 6, you'll see that 2.75 changed to 3.3, because this value, the index value, is dependent upon this value. So everything that the ultrasound machine calculates, the system will recalculate, so you never get out of whack. There's different things for valve measurements. It works for prosthetic valves, stenotic valves, regurgitant valves, all the different diseases that can happen with the valves. And then the main page is right here. And so there's a lot going on this page, but it's actually quite easy to use once you get the hang of it. Usually takes about 5 to 10 studies, depending on the doctor or the tech, to kind of get to know where everything is. And there's a couple of buttons on this to make it really quite easy to use. One is the copy from previous button. So if this patient has been done in our system prior, if you click that button, it goes in, it takes the measurements that were just performed from the new study and combines them with how this screen was filled out the last time, so that it gives you a really good starting point. Because typically things between, let's say, a year, maybe even 2 years, they don't change that much. So if you had a problem with a thick heart, where the walls were thick 2 years ago, chances are you're still going to have a thick heart. It gives you the starting point, and then you can adjust the report from there. You don't have to use it. It's a convenience. There's also a place right here where the technologist can leave a note for the doctor. So some problem that they saw, and this will allow them to communicate without actually having been in the same room at the same time, which is often the case in these sort of workflows. We even have a templating system here so that you can add different phrases. Each tech can have their own phrases if you want. And we'll show you this template manager as we go along. It's a very nice feature, especially in areas where, you know, if the doc's used to dictating, we can make a template that helps them transition. So you've got this situation where bad apical windows. If I click that, then this note is passed to the physician. It doesn't end up in the report, just goes to the physician. And so when I'm doing my interpretations, all I go in to do is to add things that I see that are abnormal. So let's say I also noticed a little bit of regurgitation, which is backwards leaking of the mitral valve, and I saw that. But really everything else in the study is about what I expected. I can just click this all else norm button and I'm done. So the two workflows that I'm sure Rhonda covered while I was rebooting, one is that it's sometimes the sonographer does just the study and then passes it on to the doctor. The other workflow is the sonographer does a preliminary interpretation and then passes it on to the doctor. In either case, the doctor gets to this screen and then can either use these buttons, or the sonographer can use these buttons to finish constructing the report. But from when I opened this study till I got to this page, if I hadn't been doing the demonstration, it would have taken me about 30 seconds to a minute and a half to read this report. And what we find typically is that about a third of all reports are going to be normal or near normal. And so in order to construct a normal report, you're talking about a minute, which is faster than you can dictate, and also much more accurate than any kind of dictation methods for numerous reasons. This report is going to be extremely consistent no matter who reads it. They're having to go through the same user interface, and therefore they construct the same report. Now that gets into questions of standardization and quality. And so if your lab is interested in those things, which I'm sure it is, then we can help with that. In addition to that, if you want to go further, then, or you may have already have done this, is apply for accreditation through the IAC, the Intersocietal Accreditation Commission. So you have that option, and we can help you support that. So if you're transitioning from dictation or paper systems, this is a monumental leap forward. Even if you're transitioning from maybe a different reporting system that has some similarities to this, I think the docs, once they get used to this, will find that it doesn't have a lot of this combo box. Like if I chose bicuspid here, and then I wanted to make a change to that, I can't do it. It's locked. Whereas in our system, you can just make a manual edit, and it's great, and it will stay there unless I come back here and change this to something else or nullify it. And then it will warn me that I changed it. And so as many ways as possible, it's showing me this red 2 and orange 1. If I click on that, it's showing me that some things that I expect to see in this report aren't there yet. And that includes study quality and study type. Well, the system will generate a normal study by clicking the all else normal button, but there's certain things it can't do. And it can't make an assessment of overall study quality, and it can't tell me exactly what kind of study I'm reading. Well, I know where those are. The study type is right here, and the quality is right here, but I can also go up to this and say, oh, click on quality. Here's quality. Yeah, it was an excellent quality study. And the study type is a resting transthoracic echocardiogram. Now, all I have is a warning, which I can choose to ignore or keep. And if I choose to look at it, it's telling me that there was a measurement indicating that there's some amount of tricuspid regurgitation, and that's indicating maybe some high blood pressure in the lungs. but I didn't say in my interpretation that there's any tricuspid regurgitation. And so normally I'd quantify that. And I want to say that there's moderate tricuspid regurgitation. Oh, and I forgot to say the direction of the tricuspid regurgitation. Well, I don't care. I'm going to say I don't worry about that. I've now got my study. I can free text if I want to. And then I can also look at wall motion. And so wall motion scoring is something that can be very tedious on an echocardiogram. Either it's dictated or somebody has to type it or whatever. And so what we've done is created a way to do that really easily. And so if it's normal, you can just click a button, normal, and then it says no wall motion abnormality seen in the report. Or I can say everything is not moving well. So this is in patients with cardiomyopathies where there's nothing regionally wrong. The septum of the heart and the lateral wall of the heart are both contracting the same, but just not well. So in that case, I can call it hypokinetic, and then it doesn't make sense with the way I've got my ejection fraction, but that's fine. And then the third thing is I can say there's hypokinesis, but it's only in some part of the heart, and then say the rest of the heart is normal. And so I can now it's going to say in the conclusion wall motion abnormality seen. But here in the detail, it will tell me there's a small hypokinetic area of the inferoseptal wall from the base to the mid wall. Remainder of the LV functions normally. And so this sort of system, no matter what I click over here, I'm going to get a grammatically correct sentence that says how large the lesion is, where the lesion is, and that gives me great flexibility in my reporting, and it's very easy. The other thing is that when I get to the point where I'm actually creating the report looks great because it has a picture in it. Not only does it have the text talking about the hypokinetic areas, in case, for example, I had to, sometimes my electronic medical record can't support PDF files or files with images in them. Well, that's fine. Doesn't matter. This is a nice to have. So it will work just fine because the text of it is in there. And also when I fax it, it's designed in such a way that if you look at it, you can see that there's numbers that it corresponds to the areas. So if I come out and I only print this in black and white, it's still visible. But if I do have a color printer, I'm looking at it on the screen, then I have everything I need and it looks great. One of the things that we always think about is the quality of the report important? And of course, performing the report and the accuracy of the report is very important. And we assist in that way as well, because we're doing the validation and making sure the report contains all the proper information. But in my opinion, it's also important to have a report that looks good, because especially if you're doing work in both in the hospital and outside the hospital, the better looking the report, it's like your product. And so you want it to look sharp. And the better it looks, the more professional it looks, the more likely you are to have more referrals based on that information, given even like the same level of quality of the studies. But with the validation steps that we have in here, plus the fact that the application is designed in such a way to avoid any kind of errors, that you will get a really high quality report out of this that is self-checking to make sure that you're getting everything according to the standards on as many, if not every, report generated. And that's a great thing, because when I read, I get phone calls and I get interrupted, and so then I go back to the study and did I miss anything after that? And sometimes I'll have to go back to the beginning and reread it, but the system will catch me if I missed something, like it did here where I forgot to comment on the tricuspid regurgitation. It told me that there has to be tricuspid regurgitation, because if there wasn't, I wouldn't have been able to measure that velocity. So, and there's hundreds of checks in there to make sure this thing's doing what it's supposed to do. And then there's also stress echocardiograms, and so we can the staff can fill this out. If you have a relatively recent vintage stress treadmill machine, we can pull the data in here and fill that out automatically. The doctor can do his electrocardiogram interpretation here. We can pull a PDF of the electrocardiogram done on the study, put it here in the attachments tab, so the doc doesn't have to worry about paper. It'll all be right here. And then you can do all the different kinds of stress protocols. So there's a Bruce, modified Bruce, dobutamine, and Naughton. And if for whatever reason you have to switch midstream, which happens fairly often, you start somebody on a Bruce protocol, it's pretty severe. because of musculoskeletal problems, they really can't exercise well enough, then you can switch that to the incomplete stress test and then switch them to a pharmacologic test, for example, and then report out both. Because in that situation, it's really advantageous to see that they weren't able to walk on a treadmill. There's relevant diagnostic information just in the fact that they failed to be able to exercise on a treadmill, and you want to be able to report that out, and this provides that. And this workflow, just for the echocardiogram, allows for doing a routine transthoracic echo, a transesophageal echo, or a stress echo, or a combination of a regular chest wall echo and a stress echo. All of those flow well. We have modules for pediatric and fetal echo. Those tend to be done at large academic centers. If you would like me to review those, if someone could just put a comment, I am glad to do that. But there's a lot for us to cover today, and it may be better as a one-on-one if that's an interest to you, because for the pediatric and fetal, it's a little bit different in the fact that the disease processes in children are mostly congenital abnormalities, whereas in adults, it's mostly acquired disease caused by hypertension, diabetes, and coronary artery disease, high cholesterol, all of that. Whereas for kids, it's the heart is malformed in some way, or there's some other problem going on. So the way a study is performed is a little bit different, and the reporting is definitely different. The other big difference is that for adults, we adjust for body size in a different way than we do for kids. For adults, it's basically we take the patient's height and weight and calculate the body surface area, and then take every measurement that is relevant and just divide it by the body surface area to index it to the person's size. For a child, it's done using something called a Z-score, which is sort of more accurate method that has had every single measurement tested on normal and abnormal children over the years, and therefore isn't it just divide by a certain number, it's adjust for each measurement based on a normal distribution, which is a more powerful tool. So if anybody wants to see that, if enough people want to see that today, we can do that. Someone hopefully who can see that text will let me know that. Otherwise, I can continue on. And even for this, there is adult congenital. So if somebody comes to you with a congenital heart defect, there's still a way to report on it. It's just not nearly as detailed as it would be in the pediatric and fetal modules. So once I'm done, I've satisfied all the requirements over here. All the errors are gone. There's just this one warning I don't care about. I can just click the sign button, and then it will sign it. Once it's signed, it will be sent back to PACS. It will be sent to the ordering system, and then the doctor or the sonographer can move on to the next study. So that is the workflow in a pinch. There's a couple of other features that we have. So one's related to training, and so if the sonographer creates a preliminary report, and the doctor creates a final report, there's a differential function that you can use to see what the doctor changed from what the sonographer had put in. And so this is a great feedback for the sonographer to say, all right, what did the doctor change? Well, it didn't change anything on this one, but had I changed something, you would be able to actually see the changes here. So that is a great thing. So if I want to know, if I want to learn, I can just go back and quickly look at the diff. In fact, that can be part of your standard process in your lab, is that you want to review all the studies and see what the physician said at the end of the day. And it doesn't take but a couple of minutes, and it's really quite helpful. It's also important if you're looking for accreditation, and there's other things that we have in here to help with accreditation. One of them is this study tag feature. And so we can set up these tags. You can set up these tags however you want. Give as many tags as you want, however you want them named. And one of the names might be IAC Echo accreditation. And so instead of at the end of the process, when you're about to submit your IAC accreditation or your recertification, that you have to go find 10 or 20 good studies to submit, you flag those studies as you see them along the way. Because as a sonographer, I'm going to know that this is a great quality study. This is one that I've done all the measurements and I have all the views and I'm set. And so I can flag that here with the tags, and I can tag each study multiple ways. So maybe it's a great aortic stenosis case I want to use for training. maybe it's accreditation, and I can have it both. So I can say it's aortic stenosis and anesthesia risk. And now this study tag is flagged in those two different ways. And, you know, I didn't really mean that one, so I can take it off. But now I can query the system based on study tag and pull up all of the studies on the work list to see which ones I want to pull for other purposes. The other thing here I think we can touch on is that the system is mapped for almost all ultrasound machines. So whatever machine you have, the information should just flow in here. What we typically do during Go Live is we ask you to send us one study with every measurement type that you want. Open it, see if it all goes where you expect it to go, just to make sure that our systems are in simpatico. And then if there's any changes that need to be done, we can do them right here. Essentially, we'd see the SR file that comes from the ultrasound machine here, be able to then go to unmapped, and you'd see any of the measurements, and then you can just basically drag the measurement that you want on top of the field here, and then from that point on, that measurement will go to that field. So really quick and easy, even if there are some differences in the way you have your machine set up. So there's some other minor stuff here, but I think that covers sort of the flavor of echocardiography. I'm going to move on to vascular study, and we can talk about those next. So we're going to close this one. And normally it would have closed back to the setup, but I didn't actually sign that one because someone may ask me to relook at it. All right, so this is a vascular study, and so vascular ultrasound comes in multiple flavors. So basically, if you look at it here, we have transcranial Doppler, and then carotid, upper extremity artery and vein, dialysis. This is dialysis graft evaluation, and evaluating the patient for a dialysis graft and evaluating the dialysis graft itself. Aortoiliac studies, mesenteric, renal duplex, abdominal venous, lower extremity artery and vein, and then finally recommendations. And so the way this sets up is if I'm doing a carotid study, for example, then I have all of these possible measurements that go right here, and they would come from the ultrasound machine. And then I can simply read the study by saying, all right, the right side is normal, and on the left side, for example, I saw a degree of stenosis, and you can see here there's a tooltip that's telling me exactly what I should expect for the results, and then everything else on this side is normal. I can do a drawing. If I had measurements, and so I don't have them on this example, but I'll put in a couple, and I think you'll get the sense of the way they'll appear in the report. And you can see then that table will format on the right-hand side, and then you can see the text and then the conclusion. If you want, sometimes the vascular doctor will want to put some color to this. This is a little bit sterile, but it's very accurate. And so if the doctor wants to, this is that templating thing I was telling you about. So the doc can create his or her own templates, and then access those, and then by clicking here, add a finding to the report, which will then put it at the bottom of the report. So there's all of that. And there are, in this application, and I'll go into a bit more detail as we go, there's a lot of detail. So in the carotids, it's pretty straightforward. You're getting velocities systole and diastole at various sections along there. There's the vertebral arteries, the subclavian artery, et cetera. This is one of the simpler applications. The upper extremity arterial study has there's a couple different methods that can be used. One is segmental pressures. And so it's essentially looking at blood pressures using blood pressure cuffs in the various places along the arm. So you can put one in the forearm, on the wherever you need to put them, and then measure the blood pressure using either pulsations or most likely some kind of non-imaging transducer to pick up when the velocities begin and end, and then look at the pressure cuffs to know what the pressures are in that area. So that's all given in millimeters of mercury. It's also possible to use a PVR system. So if you have PVRs, and then again, it's a variation of the segmentals where the blood pressure cuff is inflated to to a pressure that's around the blood pressure of the vessels, and then you can see the pressure inside the cuff pulsate as that area is basically filling up with blood due to the pressure of the systolic pressure. There's straightforward, sometimes I'm just going to use a non-imaging transducer and quickly get a couple of velocities. I can report that, or I can do a full duplex examination. So I bring in my ultrasound machine, I scan the left arm, I scan the right arm, the artery based on some kind of musculoskeletal problem. And this test allows me to figure that out. Cold Sense puts their hand in a refrigerator in July, their fingers will turn white, and that's much more common in certain genders and also in patients who smoke. So I want to know that, and I can actually test for this in the lab by making one of the fingers cold or the whole hand cold and testing that. And so this allows me to do those sorts of reports. When it comes to arteries, that's all about velocities in the vascular realm. When it comes to veins, it's more about a description of what you might see. And so there's really a couple different things that we look at for venous problems. One is there blood clot? And the other one is there varicosities, or bulging and dilating blood vessels due to incompetence of the valves or other problems associated with swelling that have extended the blood vessels in such a way that they can be visually seen. In the arms, it's very rare to see varicose veins. It's almost all in the legs. So there's no varicosity section here. But if I want to comment on the right and left arms, I can basically say looks like there's thrombus in the internal jugular. It has collateral, that doesn't make sense. It has thickening along the vessel. It is hypoechoic, is a kind of description of what the user is seeing, and it's blocking the blood vessel, which is going to be really bad because this means that the right side of your brain can't drain blood. Never a good thing. And there's other arteries here, and you can do this for all of them, and then the report's going to construct itself on the right-hand side. It is possible, as I said before, to do combined reports. So you have the ability to and the most common combinations are things like, I'm going to do an aortoiliac study and then combine that with a lower extremity artery study. But you can combine any types of studies that you want, or you can keep them separate. It's just really dependent upon how they're ordered. And again, there's always a normal or all else normal button that makes entry of the rest of these things very easy. If you're looking to determine whether or not a dialysis graft can be placed in a certain vein, then you can use this test to figure out the diameter of the vein, because that's the relevant piece of information, and then mark which ones might not work by clicking the too small. If you're looking at a fistula or a graft, then you can make the determination of whether or not the thing is patent and whether or not the flow rates are high enough. And so that's what the fistula and graft assessment portions are for. So that handles dialysis. Aortoiliac contains the information about the aorta, and we use what we call phrase generators. And so in this situation, you'd put in, I have a 5 centimeter long aneurysm that is, well, let's make it a real aneurysm. So let's say it's 10 centimeters long, 5 centimeters in diameter. It is saccular, tortuous, starts above the kidneys, and then extends into both iliac arteries. And I click a button, and instead of having to dictate, I get a phrase. The phrase is very consistent, and I can do that for dissection, calcification, atherosclerosis. For the iliacs, I have a similar system of entering phrases, and I also have the ability to put in drawings. And so I can say, okay, here is my aortoiliac aneurysm. So it goes from above to below the kidneys, extends into the iliacs. So I can just leave this in the report, or I can sketch on it a little bit farther. I can put in annotations, whatever I want to do. And so we'll be constructing into the report as well. For mesenterics, this is, you can do these, there's a brief history. In fact, there's a history if you want to use it for the entire thing that's focused on vascular abnormalities, but the mesenterics have their own, because the disease of the mesenteric arteries cause problems where if after you eat, you get abdominal pain because you basically have ischemia of your abdomen. And then you have the different vessels and how they look. And then finally, you can get measurements, but you do the measurements before and after you've given them a meal, a standard meal, which then should cause the velocities in these arteries to rise based on the fact that they should dilate to allow for processing of the meal. And so you can utilize the baseline and post for all the different vessels to determine whether or not somebody has what's called mesenteric ischemia. The kidneys, you want to have the ability to look at the big vessels in the kidneys and the smaller vessels in the kidneys to look for blockages. These are very important values. If you have blockages, especially on one side of the body, you can end up with severe high blood pressure, reduced kidney function, all sorts of nasty. So this test allows them to document, creates the report associated with that. Something simple like abdominal venous, the inferior vena cava, various feeder veins. Are there any blood clots? Are there any genetic abnormalities that might be there? Pretty straightforward, but also an important test. Lower extremity artery. So again, this is one of those situations like the upper extremity where you may just have a couple of blood pressures that you got off a blood pressure cuff. There's a simple test that you can do called an ankle brachial index. And so essentially you put in the brachial arm sort of as a control area, and then you measure the blood pressure down low in the leg. And so you can measure the dorsalis pedis and the posterior tibial arteries. And if you put in the blood pressure for each of those, it will calculate a ratio. And if that ratio is out of whack, it's an indication that there is some degree of vascular abnormalities on that side. It's a very quick, easy, relatively inexpensive test. But if it's negative, you're good. If it's positive, then you can immediately go on and do additional imaging, or you can schedule for a different time. So there's ankle brachial index, there's toe brachial index, so you can go even further down. And then the pulse volume recordings, like we talked about before. You can go in with a non-imaging probe and just pick up a couple of velocities, or you can even do a stress ankle brachial index where you do it at baseline and then you have them walk, and there's different protocols, and then we can graph out the results of that. And then there's the full duplex examination. This is basically top to bottom. You're using the transducer to do a couple different things. One is that you're looking to find the velocity, and so you're kind of getting the velocities of all of these, and they're corrected for an angle. And then you're also looking for abnormalities, and so there's visual things. So is there a clot? Is there atherosclerosis? Is there various elements of thickening, and so or stenosis? And so you can comment on all of these. There's that pulse volume recording. There's actually a device called a Parks Flow Lab. We have a full integration with the Flow Lab. So if you use the Flow Lab, you can pull the data in here. It will show you the waveforms and then allow you to do your interpretation. If the patient has a graft, then you can, like an aerobifem graft or a fempop, then you can measure the velocities inside that and then determine whether or not the graft is patent. There's also a mapping tool here for the leg arteries, and so you can sketch on any abnormalities that you might see. Pseudoaneurysms are possible. You can comment on those. So that's the lower artery. Lower extremity vein, again, kind of like the arm, except in this situation, we have the ability to say that, yeah, the right side's normal, but now I see acute thrombus with with a tail, hypoechoic, and partially occlusive, and everything else on that side is normal. So really, you saw how fast that was to construct that kind of report, really quick. But in the legs, then you also have to worry about spectral analysis and reflux. And so reflux is due to the venous incompetence because the valves have deteriorated or other reasons. And this, again, works very similarly. So the right side's normal, but on the left side, I see moderate abnormalities of the greater saphenous, the proximal segment. It's enlarged. It's 6, I don't know, what's an abnormal value, 15. The reflux lasts for 2 seconds, which is a long time. and then everything else on this side is normal. So again, really quick, really easy. I've got a table of data. I have abnormalities for both reflux and duplex imaging, and I even have a drawing tool here to use, so I can sketch either the calf or the posterior calf or even superficial, and then I can just draw on this. So for example, if I saw varicose veins, I can just say, all right, so I see varicose veins here and here. And then if I see blood clot, I can change the color. I can make it different. I can make it fuzzy to indicate. And I can even click on here and say, you know, severe. Sorry. And then you'll be able to see then in the report, it'll say whatever I typed here. So the drawings are very flexible. We have a good set that we provide with the system. If you have your own set for some reason that you want to use, then by all means give us that set. We can plug those in here instead. And then finally, there's a recommendations page. I can send off recommendations. Again, I have a template. Any comparisons with previous, I can do that as well. I didn't show you that for echo, but it even knows so that's basically what we do for vascular. And then this report is, because I've been putting so much stuff in, it's going to try to combine them all, which is going to make it look kind of silly. But again, the study quality and the study type here will allow me to then finish the report, and then I can sign it once I'm done. And then this will go follow the same path that the echocardiogram did. Okay, so that is the vascular studies. And you can see on the right here, there's fetal echo. We've got some radiology things like scrotal, OB, musculoskeletal, abdominal pelvic. All of those are possible. It's NovaCardio, so the NovaCardio part is really focused on the cardiology components. Just know that we also, because of the similarities of ultrasound imaging, we also have the ability to do various radiology applications. And I'll just touch on one here as a sort of to give you a sense of what we have. So let's just look at an abdominal pelvic ultrasound. Again, measurement driven. So you have the ability to look at various abdominal and pelvic portions. The female and male pelvis, they're broken out because, of course, they're going to have different structures in them. But you know, you can do a partial study, you can do a complete study. There's a place for all the different dimensions. They'll all come from the ultrasound machine, populate directly into these reports. Fairly extensive things for the kidneys, and then for the pelvis, for the female pelvis, you're looking at uterus and ovaries. For the male pelvis, you're basically prostate, bladder, pre and post void. And you've got the bladder pre and post void here as well. And so you can construct, you can send a tech note. Again, with the templates, you can create an MD note. So you can utilize this so that your sonographer, for example, can do a preliminary and then present the preliminary to the attending. And they can either just sign it, or they can use the MD note section to append something, or they can go back and they can edit the report itself and change the user interface. All of that's possible. So they can go back in and, you know, edit it at this point, or they can just free text something here, or like I said, dictate or use a template. So the beauty of this is that in an all dictated summary, you don't oftentimes get the numbers unless the doctor has dictated the various values into the report. Dictating values has some chance that you're going to dictate the wrong number, or it's going to be misinterpreted. It's not going to be formatted into tables. And so we can provide sort of that level of flexibility and control of the output display in a very uniform and attractive way that is highly communicative of the result that you want to be able to send back. Let's see, what else we got here? CT angio. There was a question on coronary calcium scoring. Rhonda, do we have a coronary calcium one queued here, or should I? Oh, there it is. There's one.
Do.
I'll just use this one. Okay. All right. So we have a there's a basic one built into the PACS viewer. You can utilize that one for coronary calcium, but with the one in Encapture MD, then we can sort of take it to the next level. So you can utilize patient historical information to not only calculate the coronary calcium score, but then use that to compare it to previous calcium scores, and then the various risk assessors like the Framingham risk or the UK risk score or the CAC, the Canadian risk scores, and then utilize that information to put a calculation of risk for the patient. And so this graph is showing me what risk percentile I'm in. So this particular patient is in like an 80% risk percentile, which is it's a pretty high risk. So it's adjusted to 80, intermediate, but it's pushing high. And so the report itself then has even more detail. And depending on how I have this configured, I can put the graph in there, I can leave it off. And then again, all the validation, we've completed this one well enough, but report looks great. And then I can sign it and then move on. So what was the question? What was the specific question on coronary calcium? Rhonda, did you have that?
Yep. It was, how do you recommend getting that report into NovaPACS?
So all the reports they're created will go back to NovaRad. So they'll also be routed to the ordering system as well by whatever mechanism is required for your facility. So if you send an order, you're using DICOM modality work list, the CT scanner picks up the work list. If your scanner can output DICOM structured report information for the coronary calcium score, or if you do it offline, then you can populate here, then the report creates, and then it goes straight back. If the one that Tony showed earlier is already in PACS, but this one goes straight back. And from the user's perspective, none of that is going to matter to them. They're just going to sign this and they're going to move on. And I hope that answered that question. I could use a 10-second break here. So were there any other questions posted in the chat?
Yes, I have one for you. Can you add custom elements to the calcium score report, such as a risk stratification explanation table? I'm so sorry.
So that's what this is. This whole page right here that I'm showing you is a risk assessor, and then you can see in the report itself the score, the arterial age, the Framingham score risk, the adjusted risk, et cetera, and then the overall risk is reported here. So yes, absolutely. Any other questions that came up?
Not that I can see, no.
All right. So just to let you all know, my my throat is starting to get numb because I'm talking so fast, but I will continue until I'm hoarse. So let's move on here. So there's coronary calcium. There's also coronary arteriography. So you can do those with our system. So where is it? CT angio. So with CT angio, then you have the ability to do anywhere in the body, the various abnormalities. You can talk about the plaques, the artifact that you might see, abnormalities of the great vessels, vertebrals. Then you can move all the way down through the different portions of the body. And so that handles sort of all the peripheral arterial studies that you would do with a CT scanner. We have, and if there's interest, somebody let me know in the comments and I can go into more detail here. We also have the CT angio for coronary angiograms. The nice thing about that one, let's see if there's a study I can pull up here. I'm going to use one of our sample patients. And let's see, so this is coronary CT right here. All right, so the advantage to this application is that I have a coronary tree tool, and I can add coronaries. It constructs the report for me. I can put in stenoses or abnormalities. It puts those in the report for me as well. And then the report itself, not only does it contain the description, it also contains a picture and it's really quick and easy to use. We also have the information about how the scanner was set up, and I can just click the standard button. Any medications the patient might have been on, heart rate during imaging was 67, the contrast type I used, and a lot of that can be set on this standard button, so I don't have to fill it out each time. We also have the ability to do coronary calcium scoring here. It's not as advanced as the coronary calcium. It's more of an incidental finding in this one. So you could report it out in both, so not a problem. There's also non-cardiac findings that it might have picked up. So something in the chest, in the hilum, whatever else is in the field of view they might want to report on. And so this is the report for a coronary CT angio. Excuse me.
Dr. Scott?
Yes, ma'am.
Just to let you know, we did receive a question about adding a custom table if needed to the coronary calcium.
Sure. Whoever's the coronary calcium guy out there or person out there, I appreciate your questions, and I'm focusing on it. And the answer is absolutely yes. So to give you an example of that, I'm going to open up our application in what we call developer mode. And so in developer mode, I can do everything that we as designers can do. So for example, there's a general tab, and this is and I can add a sub tab to this, and we're going to call this one new table. And then click that, and I'm going to basically, I can go in here and I can grab various elements, and I'm not actually going to do it because this is a real study, and basically create a new table, define the columns and the rows in the table, and then have it easily filled out, and then be able to incorporate it into the report wherever I need it to go. So this tool is really fascinating. I can actually control how the thing works. So for example, under vessel right here, I can double click on vessel, and then a little editor pops up, and here are my vessel choices: brachiocephalic, right common, right subclavian, left common, left subclavian. I want to add a new one. I can just click plus value, and then that goes into an action, which means that if I click a button, something happens, or if I change this, something happens. I can put it into a validation. It has to be required to be there. I can make sure that it goes to a specific report, or it goes through a sentence, and where it goes in the sentences, and all that's completely configurable. We can do that for you. We can do that with you. We can train you how to utilize this tool to do self-customizations. All of that's possible. It's not hard to use, but I think more it's knowing less about how the software works and more just sort of design things, like where should I put it, and how should it work, as much as it is like how did I change that one combination box. So I'm going to go in and delete this new table thing that I just created because I don't leave it there. And so that's the ability to add or change any of these applications to conform to your standard workflow is possible. That being said, I think what you're going to find is that we're really close right out of the box, unlike a lot of systems where they'll tell you, oh yeah, like your EMR will say, yeah, we can build that for you. And what that means is like 6 months to a year of work to get it to be exactly the way you want it. Whereas with us, it's like, after the first couple of weeks and you've gotten to use it for a while, you're going to say, hey, we need to change this and that, and then it's done. So a lot less effort than building it, quote, we'll build it for you. So yeah, closing this. So the other things I wanted to show are, let's look at nuclear cardiology. So this is nuclear stress and MUGA scans. MUGA scans have sort of fallen out of favor and changes in left ventricular function with chemotherapy, for example, but it's still available. So and by this point, you've been looking at our applications, you can see there's commonality, right? They're all going to look very similar. They're obviously going to have different screens for different functionality, but there's always a study tab. That study tab then contains the relevant information for that study. There's always a patient tab. There's always a billing tab, but the billing tab is going to be adjusted based on the type of procedure. Always an attachments tab. And here's an attachment, so you can see what that looks like when there's something is attached. And this is just a screen capture of the nuclear image. There's oftentimes then from that point on, those first 4 tabs are always on every app. After that, it varies based on the application. So the and then, but so now for nuclear, then you do have the ability to do a brief H&P, and it can be as extensive or not. And there's different workflows here that are relevant. Some places will have an acute chest pain protocol, right? So somebody shows up in the emergency department, acute chest pain, they basically take them back to the scanner immediately, inject them with tracer, and image them. Because if they're actively having chest pain, they should have a defect. If they don't have a defect, then it's unlikely that this chest pain is coronary related. So there are places that do acute chest pain protocols. There's certain medications that you want to make sure haven't been given. There's other testing that might have been done outside of the facility. There's basic history information. Now, use it, don't use it. It doesn't really matter. The report will format itself around anything that's not there. It won't be like a big block of missing data in the report where it will say patient history and then nothing will be under it. No, there just won't be anything in the history section. But in here, if you take a couple minutes, then you can provide context for the result when the referring physician is reading the result, which is handy. And then, I should know my patients, but it's handy to see that, that when you did your interpretation of this as the attending, that you knew these risk factors. And it's also important for pre-test probability sorts of things that the attending physician who's reading it using Bayesian analysis should be able to know, is this patient high risk to begin with? I mean, if they're a 21-year-old who with no risk factors, and they have a positive study, it's very much likely going to be a false positive study, but it still needs to be evaluated. When I read, I don't want to read in isolation. I want to be able to read with additional information. Not everybody does that, but that's my thing. So I want as much as possible to know these things ahead of time. And so if my staff gather that up, this is a place for them to put it so that when I get to this point, I can see it all. Now, the stress portion of this should look very similar to what I showed you for echo, although this one's filled out. So this was this was successful stress. This is Bruce protocol. They had a little bit of atypical angina during the examination. They went 5 minutes and 3 seconds, 2 stages, and then they achieved a proper heart rate, more than 85%. That and exercise capacity. Any more problems during recovery? Yeah, abdominal discomfort. And then I have an ECG interpretation. So this is what that looks like. And then a stress interpretation. And for the this is what a table looks like in our system. So there's an output form, and then you can double click on it. In the output form, you can have as many columns and as many rows as you need to. Anything that I put in here, it'll look exactly like that out here. Stress ECG, there's a phrase generation that we use to positive or negative. And then we can calculate a Duke treadmill score. We set up there's a standard protocol button. We set that up to be whatever protocol you normally use. And then all you really need to do is add the dose if you want the injection time. And then the report will be formatted accordingly. If you gave meds during the procedure, we have a medication module. You can add the meds. So maybe you gave aminophylline